replacement therapy, also known as menopause replacement therapy. There's a lot of different terms people use for this. Today is kind of the history. Um, and I'm going to go through a couple little disclaimers here. So, first of all, I worked hard to learn about menopause to make sure I was treating women the best way possible with their symptoms of menopause. Um, Yet in medicine, we are frequently, um, it's a mentorship profession where we take a lot from what we're told by those that mentor us, and I have great reverence and gratitude for those that mentored me. Um, but as we'll talk a little bit further along, but very little education is given specifically on menopause. And we're going to kind of go through the history, and you can kind of see where there's been some shifts in treatment. So the first thing I wanted to share is estrogen. This is the coolest thing. Estrogen, first of all, in utero, will help a woman's body develop the reproductive tract that makes up their specific gendered body. When a woman then has a child, there's an estrogen surge, which causes specific symptoms. And these symptoms include hot flashes, sleepless nights, and vaginal dryness and brain fog. And as you think about these symptoms with this estrogen spike, um, it is actually to keep another human alive. The hot flashes, it radiates heat to this little infant that is either nursing or being held by the mother. The sleepless nights are so the mother can be on alert and be able to address needs of this baby, because without the mother, um, the argument goes that there would be very little or low risk that this infant would stay alive. So this estrogen surge has kept this infant alive, and these mothers sacrifice so much. Well, what happens then? Their reproductive age starts to come to an end, and the estrogen surge and estrogen spikes then begin to diminish. And nearly every cell in the body has estrogen receptors. And as there's this depletion of estrogen, there's this symptoms. And these signs now to this mother or woman is there is now another individual that needs to be kept alive. And my argument is that it is the actual mother, this individual that has sacrificed her life to help their children and other children. And now it's a time to be able to focus on their individual health to become rejuvenated, refreshed, renewed, and be able to have a continuation of wonderful years. Maybe not reproductive for children, but have wonderful production of adventures and memories and really soaking in life of the hard work they've put in for decades raising children. Let's enjoy that now. So that's kind of the initial story I wanted to start with. Disclaimer: there are medical experts that I have absolutely loved following. Heather Hirsch is one. Mary Claire Haver is another one. Fantastic books, fantastic resources, and just want to say thanks for their work, being my new mentors. And then also there's a society, the Menopause Society, that's been extremely beneficial. I'm a part of and working on certification for or from. Again, this is not medical advice. This is strictly educational. And this information shouldn't be used to diagnose or treat symptoms. And the one thing I do want to say is, educate is advocate for yourself. Individuals that are going through menopause, it is tricky. Not every physician is trained in menopause replacement therapy. Not every physician agrees with it. And so being able to find someone that can work alongside of you to advocate and to go through this with the understanding that you know your body best. And that's where we can, use physician education and then your symptoms and come to a great team there. All right, so history. Okay, we've talked about the accomplishments of women that their uterus stretches to like 500% times. All the changes they go through. I'm preaching to the choir, you're hearing, you're like, yeah, I've experienced it. Like, you don't need to tell me, the accomplishments I've had. But I just want to take a time to say thank you. Like, thank you for sacrificing what you have, what you've gone through. In Greek mythology, they had um, they had something called uterine melancholy. And it wasn't a diagnosis, but it was a definition of what happens to a woman when they go through basically menopause, and they said that there's a disturbance in the reproductive organs of a woman. And they said that the uterus would migrate to different areas, that there would be a toxic, what do you call it? Something in the air, a toxin that was roaming around that would cause hysteria, that would cause breathlessness, anxiety, and madness. And they kind of said, all right, we've defined this, right? Here comes Hippocrates, late 300 BC, or sorry, yeah, BC, and he called hysteria. And hysteria is, hystera is uterus. That means uterus. So the word hysteria came from this is when these women have this hysterical symptoms and all these things going around, and this symptoms of emotional volatility and sexual dysfunction, seizures. It just was like we can't explain this, so it's called hysteria. Um, fume. That was the word I was thinking. Toxic fume. So anyway, that's kind of like a little bit of the history of this. Um, Mary Claire Haver actually goes into her book and talks about these symptoms. And so I'm just going to put a couple up, just a few symptoms of menopause, and you can count to see if you've had any of these symptoms before. So here's not a small list. And yeah, I could go through each one of these if you'd like. But I think the point is, again, there are estrogen receptors throughout the body. And when there's a deficiency of estrogen, we can certainly see symptoms. Now, quick disclaimer, right? Um, let's see. Let me just pick a couple out of here. Acid reflux. Is that due to menopause, or could that be from a hiatal hernia? Could that be from the food we eat? What about migraines? Could this be from a history of concussions? Could this be from, eyeglasses that are too strong or too weak of a prescription? So, like, I think this kind of goes into a lifestyle element of functional medicine, of medicine, that while we could point the blame specific to one hormone, maybe two, or whatever, like the reproductive hormones, um, there are, again, this is a plug for lifestyle. There are other elements that can also improve slash augment menopausal replacement therapy. And it's important also to kind of see this in a kind of a whole person approach. And it's fascinating and fun to hear the lifestyle elements. Sarah Berry is a researcher. She works with Zoe that does a lot with food and fiber and improving gut health. And she was talking on a podcast, and she's like, look, I'm going through menopause or perimenopause, and there's these benefits from medications, but yet lifestyle factors also play such a great role. And I really appreciate that. She's a huge researcher, and it's just neat to see that it's this whole person approach. And I really, really like how she has a whole person approach to health and science, and grateful for her research. Let's go through the history now. Okay. Well, we've kind of been through it a little bit with hysteria and the toxic fumes, but in 1923, Edgar Allen, Doisy, they isolated the ovarian hormone. They later named that estrogen, and they were able to identify it, right? Like this has a role, it has a purpose, and that was, that's 98 years ago. It doesn't seem long ago to me, but I'm getting older. Next is 1933, 1942. They started developing estrogen replacement products. They were developed from the urine of pregnant women. It was expensive, and they're like, what else could we do? And then they got Premarin, breaking down that word pre-pregnant, M-A-R, mare, equine horse, and is urine. So that's when they developed Premarin, pregnant mare urine that was used. And it had its place, and that's what they had. When you move to 1947, Then by that time, there was a proliferation of estrogen formulas. Actually, around 53 different menopausal hormone formulations by numerous companies, huge interest, and it just continued to grow. By 1975, there was over 30 million prescriptions written per year. So, hey, look, we have this medication. It can help. It has a place. And it was popularized by different books and articles and yeah, information. At the end of the 1970s, there was then recognition of a cancer risk, where unopposed estrogen for women with a uterus increased the risk of endometrial cancer. And so they said, well, okay, let's protect that uterine lining. And they found, if you're able to prescribe a progestin, um, then that can decrease that risk of endometrial cancer. Um, so let's see. Um, 1990s, still a ton of them. There was 38% of women aged 50 to 74 still using menopausal replacement therapy. So a lot of acceptance and said it was fine. So then let me think. Yeah, let's just go into this next part. So then there was a study that came out in the late 1990s or 1990s that had women up like 70 to 80% of women, thousands of women stopping their refill of menopausal replacement therapy. This one study. And we're going to go into that a little bit because this is where a lot of my preceptors um, and, guidelines and some things kind of developed some recommendations for menopause replacement therapy. So for me as a clinician, right, I need to make sure I understand the details of this study and other studies that have been published since to see, well, that's what the headlines published. What does the literature actually say? And so, again, in the 1990s, there was, oh, there's my little point there, but there was the study, the Women's Health Initiative. And in science, they say, let's get a randomized controlled trial. Let's get let's get groups of individuals, and some will give therapy. We'll randomize them. Some will give therapy, and some we won't, but the patients aren't going to know. And sometimes when it's double blind, the physicians don't even know, or those that administer it. We have no idea who's getting what. Neither do the women. What happens, right? That's kind of the gold standard of scientific literature to many, and that's what this was developed. And the two groups were women with a uterus and then women that had a hysterectomy, and they stopped the study early. And before they even published the results of the prematurely stopped study, um, the media got a hold of this data or even just some of the statements, and there were huge, huge claims. Um, hey, estrogen therapy causes cancer. There's a cardiovascular disease risk, stroke, and blood clot risk. And there was a huge hype. And again, like overnight, in a very short amount of time, the amount of prescriptions just completely dropped. And so I'm going to kind of go through some of these things. We're going to stay on this slide, and I'm going to kind of talk about them just a little bit. So, breast cancer. Um, Breast cancer does affect a large amount of women. It is it's devastating. There are significant lifelong consequences of breast cancer. And what they found is those with taking estrogen and progestin had an increase of breast cancer. But let's dive into the study. Let's actually look at it. Well, the risk went from 4 women per 1,000 had breast cancer before the study. And then after the study or through the study, there was 5 women in 1,000. So I don't know what that sounds like to you, but the percent increase is 0.08%, and that's called absolute risk. That's not very much, right? But when you get the relative risk, moving from a 4 to a 5, that's a 26% increase. And when we hear that as consumers say, oh, it increased the risk by 25%, it's like, man alive. I hear that and that sounds like, well, if four women take, menopause replacement therapy, one of them's going to have now breast cancer. But what does it really say? It says if 1,000 women take it, this data shows there may be one additional woman that would have breast cancer. And that might even say, well, look, if I'm going to take, menopause replacement therapy, and there's that increased risk, well, let me stay up to date on my cancer screens. Oh, and there's another lifestyle plug here. Let me do flaxseed. Let me be more on exercise. Let me do more with fruits. Apple skins. Like there's some things that can also prevent breast cancer that have some evidence to it. And it's like, let me kick that up, right? I want to prevent it. So that was a really insightful thing, learning as a clinician. Next is the cardiovascular disease risk. Um, the just a sec, I'm going to a couple places here. Um, the they found there was an increased risk of stroke, and I'm moving on. I'm going to come back to cardiovascular disease risk, but the stroke and venous thromboembolisms. It's important to note what they gave these individuals. They gave them conjugated equine estrogens by mouth and medroxyprogesterone acetate by mouth. Medroxyprogesterone is not something that I use in my clinic at this time, and also conjugated equine estrogens are not something. So it's like a lot of this data is isolated to these specific medications. By mouth, estrogens first go through phase one detoxification from the liver. And the theory is, and there's some studies to show this, which I will link in the show notes in the YouTube video, is they've shown that when we do estrogen through a patch or transdermally, that risk of blood clots or stroke or thromboembolisms actually decreases significantly. And so there's, that estrogen's not going through that detox pathway, therefore increasing the risk of stroke and blood clots. Um, Last one was cardiovascular disease risk. This is actually fascinating. Cardiovascular disease is very real and prevalent in women, and to decrease that risk is very beneficial. What they found is that if an individual starts menopause replacement therapy within 10 years of reaching menopause, that cardiovascular disease risk benefit is high. For women that are past 10 years of menopause, like after 10 years after reaching menopause, that then starting hormone replacement therapy, there's more of a increased risk, and that um, protective effect is not quite as strong. And there's also different theories, like a healthy, let me get the exact names here, healthy cell hypothesis, where it's just like, well, if we've waited 10 years, then aren't, the atherosclerosis and other cardiovascular disease risks, aren't they kind of increased, right? So there's some different theories that you kind of wrestle with. To get a study of 27,000 women is difficult. To redo these studies, it takes a lot of funding and it takes a lot of due diligence to be able to execute this well. And so there's different theories out there of like, well, we didn't do the primary literature like the Women's Health Initiative on these other formulations of estrogen and progestins, and it's a risk versus benefits discussion when it comes down to it. So what I want to do now in conclusion is just kind of show the Menopause Society's official position statement. And this position statement is supported by a number of other societies. And I can get that link and I'll put that in the show notes as well. But this is what they say. And I'm going to summarize it a little bit because I actually even decreased it from what it normally is. But hormone replacement therapy or hormone therapy is the most effective treatment for vasomotor symptoms. Okay.
Mhm.
That's a hot flash. And genital urinary symptoms of menopause and can also help prevent bone loss and fractures. So If the woman's under 60 and within 10 years of menopause without contraindications, there's a favorable benefit to risk profile. And then it talks about the risk of those 10 to 20 years after menopause, a little less favorable. So, what's exciting overall is I believe the tides have turned. I believe also there are women that are advocating for their self well and that are digging into research and literature and making very informed decisions. Um, and it's just kudos to them on all fronts. And it's just a exciting time to be a part of medicine and be able to have so much data, whether it's literature, whether it's lab results, et cetera, to help make these decisions. So that is the conclusion um, of our education session, of our open office hours. Super happy to have you here, and we'll now move to our. I guess I'm just going to say, if you have any questions or comments, drop them in the comments below, and then we will stay for Q&A just for our members. And